Hey there, welcome to Cumberland Conversations. This is the place where we talk about the issues that matter most to you, your patients, and your community. We're diving into real conversations with real people, sharing insights you can actually use. Let's get the conversation started. Hey everybody, it's Rob Lillard, Medical Director for the Cumberland Pediatric Foundation, welcoming you back for another episode of Cumberland Conversations. Today, it's another Journal Club discussion, and I am thrilled to be joined by Dr. Maribeth Nicholson from the Division of Pediatric Gastroenterology and Nutrition. And Maribeth, thank you for coming. For the audience that's listening and watching, I just want to let you introduce yourself and give your background for a second before we get started.
Sure. So I, as you mentioned, am a pediatric gastroenterologist at the Children's Hospital. I also, during my fellowship training, got a Master's of Public Health. So I am a physician scientist, so I spend a good bit of my time doing research, particularly on infections that affect children, like C. diff infection, and I study the intestinal microbiome and a variety of GI conditions in children. And I'm happy to be here. Thanks for having me.
Yeah, I think, and we're gonna get really into your wheelhouse in one of these articles, but we picked out several things to talk about today, and I wanted to start it with one that was in the April April version, I guess, of Pediatrics. And this was the new guideline for what we used to call failure to thrive, but now has been renamed faltering weight.
Mhm.
So you want to talk a little bit about that? I mean, why the name change and why you think that's important?
I mean, I do think, and they mention it a good bit in the article, I think it is a good name change. I think some of these are based on kind of public perception and also how we name the conditions that we care for in children. And so I think that some of the probably major reasons for changing this name, and one I think is really exemplified by a patient that was sent to me recently by a lactation consultant who said, this baby is thriving in every aspect of their weight.
Yeah.
Right.
Yeah.
So I think thriving rolls into it so many different factors that maybe when we used to use that term, we're really just talking about weight. And so probably thriving is not the best term. I think weight better exemplifies what we really mean by that.
Right. It almost implies that in general, maybe it's a failure.
Right.
So that things are going wrong.
I think it's also, you mentioned this failure connotation. So who's failing? Is the baby failing? Is the parents failing? And so I think that's a really kind of hard term to use in these scenarios, which are already very stressful for families, as you know. So I think the name change is a great movement to kind of better care and better label these children.
Yeah, no, that makes total sense. And so then we move into another part of the paper before we even get started, and it's the introduction of the Z-score. Okay. And for me, that's a fairly new kind of thing to talk about. Back in the day when we used to kind of chisel these growth curves in stone when I was starting in practice, it was, we talked about percentiles, and it was percentiles this. And this is a different kind of term for when we talk about growth. And I know a lot of EHRs probably don't have Z-scores incorporated into the growth curve. So tell me about that and why the importance.
Yeah, so I think there's been a movement toward this, I would say, in the last couple years. We've been hearing more about it, initially kind of in the research space and now more in clinical care. So we've been using it, particularly BMI Z-scores, to kind of designate severity of malnutrition. And so that's where I feel like in our clinic we first started using it. It's basically in simple mathematic terms. If you have, it's movement away from the mean. So for every, if you're a positive number, so if you're above 1, then that child compared to other children of a similar age and sex is going to weigh more, versus if it's less than 1, it's going to weigh less. And so they kind of move, as opposed to percentiles where somebody who's the 40th percentile moves to the 30th percentile versus 30th to the 20th. Those aren't actually standardized. This is a standardized interval. So if you go down by 1 and then you go to -1 to -2, it's the same change. So it's a more standardized way to measure it. But I think what you mentioned is also an important, that if we're going to be defining these children with faltering weight based on their Z-scores, we have to be able to measure them reliably and quickly. So at Vanderbilt, we have them embedded into weight for length and BMI and height and weight. But one of the measures that they're recommending is this change in weight over time. So a negative Z-score over time. And that's not something that we even have available in our EMR. There is a height one that I think is used more commonly in the endocrine clinics. And so they mention in this clinical practice guideline that they have a toolkit where they have these available. And they are available. You can pull them up and you can kind of plot. But it's not timely to have to pull this up for every patient. And so I think there's a lot of good recommendations here, but I think there's also going to be a time before a lot of centers can implement all of these, including us, which is a big tertiary care center. I think there's going to be some changes that need to happen.
And while you're talking about, I just want to mention, I think the website for the toolkit is available through the AAP. We're going to embed that into the show notes for the podcast. We'll have it on the video. So if you're looking for that, hopefully you can find that helpful. I think the other thing that was important is it gives you something at the extremes to kind of measure, right? Because when you get less than 5th or 3rd percentile, even our 1st percentile,
we just say less than the 3rd.
Less than the 3rd, right?
Yeah.
And so you can't, if they move a little bit, you really can't quantify that. They're still less than the 3rd, but the Z-scale gives you a little bit better measure.
Yeah, because it'll keep that number will keep going -3, -4, -5, whatever it has to be based on below those percentiles or above.
Right. Absolutely. So one of the other things I found interesting is, when we talk about diagnostic testing, and I remember, and I actually went back and I found an old Nelson's Pediatrics from the 90s, and it talks about all the things that we used to do. And I remember being taught, you should always get a urine, renal tubular acidosis. You should always, sweat test everybody. And that really has changed a lot.
Sure.
Granted, a urine is not an expensive test, but it can lead to unnecessary follow-up testing, and, referrals for endoscopies and all those sorts of things. The yield is just not there, is it?
Yeah, no, I think in this practice guidelines, when they summarize some of that data, I'm going to forget the exact numbers, but it's very low, like 5 or 6%.
I think even in like tertiary care centers where they're seeing probably the worst of the worst, it's still less.
Yeah, the yield is really low. And I think it's mainly in those babies that have other symptoms that you're concerned for, the one that already had a urinary tract infection or the baby that also throws up all the time. So ones that it's not just as simple as maybe they're not gaining weight as quickly as we want them to, but there's other family history of atopy or celiac disease or other things that seem off. I mean, I think those babies are the ones that maybe warrant screening or the more severe disease or persistent disease. But in the first visit of a baby that we haven't done any interventions on yet, that otherwise has a really normal exam and otherwise reassuring history, it seems like the yield of that workup is really low.
I think they really strongly recommended really starting with an idea of just increased calorie supplementation, be it with, enhanced foods, enhanced calorie foods or formulas or things like that before we really make a decision on what needs further workup. And
sure.
I can't believe it was 3 months or so to, and if it persisted, maybe that's a good time for referral. Yeah. What's the typical age range that where you see a lot of these folks referred to you?
Yeah, I would say we see it probably most commonly in infancy in that first year or two of life. That is the most challenging with weight gain. And we have a lot of referrals in that age. And we do probably are more aggressive. That's probably the first difference from a general pediatrician's office that's already done some calorie advancement is we get a little bit more aggressive in terms of calorie advancement. But I mean, I think if you look at the data on if you increase calories, are these babies going to grow better? We don't have a ton of data, but also I think what you always think about is, well, how could we actually study that, right? Can we actually take babies and not give them more calories and see what happens, right? That wouldn't be ethical. So I think even though there's not a great evidence base to say that this is what we should do, I think we all see clinically that the babies gain weight better when we increase calories. And if they don't, then it's time to look for something else.
Right. And I think they made that point is that even though a lot of evidence might not be there, the downside for increasing calories is pretty minimal.
Sure.
Whereas the downside of perhaps early referral or, anesthesia, they talked about that a lot. Anesthesia associated with an endoscopy can have some significant effects on children. And so something to be avoided if we don't need to jump.
Sure. Yeah, especially early life. I think there's been some models that have been concerning for if you have to get repeated anesthesia. I think it's been a little bit of mixed data, but certainly something that we want to avoid. And I would say it's a pretty rare baby that we're doing a scope on for not gaining weight. And in those, it's generally those with that family history of either celiac disease or the atopy. EOE, eosinophilic esophagitis, is one of those sneaky ones that can come up in early life. Less babies, more toddlers. And they can't really necessarily say it feels like stuff's getting stuck, so, or I'm having heartburn. So those ones that have a stronger family history of atopy that have not responded to calorie advancement are ones that maybe we're going to go forward with endoscopy. But I would say that's a minority for sure.
Maybe vomiting or other kind of
Having significant vomiting, sure.
Yeah. Great stuff. And how do you think a primary care pediatrician should really look at that and change what they're doing? I mean, obviously we talked about maybe pushing the caloric needs. Other thoughts for primary care that you would?
I mean, I think one of the movement pieces which we talked about is if we can incorporate Z-scores into the algorithm, I think would be really helpful. I think it really is a lot of calorie advancement. And I guess, we talked a little bit about there's not a downside of that in terms of risk, and that's certainly true. But I think the reality of some of these families being able to afford nutritional supplements, I imagine your experience is like mine, where insurance really does not cover these formulas without, a feeding tube, which most of these children do not require. And so there is that cost factor. And I think it was interesting and maybe a little bit surprising that they noted that socioeconomic status was not a risk factor.
I wasn't sure what to make.
I
read that a couple of times.
I didn't.
So, what were your thoughts on this?
I think the first time I even think I read it wrong because I was so expected to see something different. So I guess they didn't identify socioeconomic status as a risk factor for failure to thrive. They still recommend screening all your patients. I know our pediatrician offices around here are excellent at doing and screening for food security and housing security and all these things that really are meaningful to your patients. But I think when they looked at these cohorts, they didn't find that was an independent risk factor for having a faltering weight. And so not that we shouldn't screen for it, but that we shouldn't use that as evidence to make a diagnosis. But I will argue, I think they presented maybe 5 or 6 studies that looked at this, and only one of those was a small study in the United States. And so there's ways to really meaningfully look at that in bigger ways that I think maybe haven't been done yet. Because there is a suspicion when we see some of these families that have challenges getting formula, challenges mixing formula, especially when we're doing different recipes and have maybe language barriers. I think it's really challenging and certainly something that we need to make sure we're addressing.
No, I totally agree. I mean, I think that should be part of every evaluation and making sure that they have what they need and social needs covered. And I think they were fair. I think they said that this is really just kind of the beginning point, that there needs to be a lot of validation for a lot of things that are put up in this CPG. And so it'd be interesting to see how this plays out. But I think, to your point, I mean, going back to just starting with Z-scores will be a big enough task to carry.
Sure.
So it'll be interesting to see how this goes. And hopefully we'll come back in a year or two and see what kind of progress we've made and how this plays out. So great. Let's move on to a different one.
Sounds great.
All right. So I picked this out, and this is from the Journal of Pediatric Gastroenterology, easy for me to say, and Nutrition, again from 2026. Didn't give a month, but this is from pages 801 to 811. And this is talking about baby-led weaning, which is kind of always a hot topic in primary care, and how that is associated with later picky eating in ages 2 through 5. So let's talk about baby-led weaning first, how we define it. Do you have a particular way that you define it?
I mean, what I generally think of baby-led weaning is that when we're introducing solid foods, it's done with kind of soft, more dissolvable solids that the baby is able to grasp and self-feed. And generally, I think the thought is with baby-led weaning is that it's part of family mealtime. So they're not eating separately, they're eating with the family at the time of the meals. That's my general understanding.
And a look back, and I think for the longest time, especially when I started my career, how we counseled folks on introducing solid foods and feeding, it was very prescriptive. It was like, you start at 4 months. You start with one food. You don't do half a jar and you do this. And we kind of laid out what we defined as success,
Sure.
which again, I think probably elevated a lot of stress for mothers and families in general on, what goals were. And this is more like, let the baby kind of show you what they want. And certainly there are things we need to counsel about being ready for feeding, right? Just, motor skills, being able to sit up, not have tongue protrusion. We need to counsel obviously about choking risk. We're not starting with grapes and hot dogs, things like that. But anyway, they did a lot of studies to kind of look at it. By the way, this article was done in the Philippines, and this was in a mostly college-educated population in the Philippines, about 65 to 70% college-educated. Looking at, this was questionnaires, by the way, so there's a little bit of potential bias included there, but anyone with developmental delay, prematurity, GI conditions were excluded. And they found that in that population, about 70% or so were breastfed longer than 6 months. And they kind of teased it out into 4 categories. They had strict traditional spoon feeding, predominantly traditional, predominantly baby-led weaning, and then they defined strict baby-led weaning as greater than 90% self-feeding. They adjusted for certain things, but what was significant in the strict baby-led weaning, again, more than 90% of the time, those children had a 95% lower odds of being defined as picky eaters later on. That's pretty amazing. Now, they used a children's eating behavior questionnaire to kind of define that using food fussiness questions. But I think that's amazing because we get so many questions all the time and stress and anxiety about why won't my baby eat? And do you see that a lot in referrals, or what do you see?
Yes, we see a lot of stress around food introductions. And then because of that, which I think is also a problem, and they touch on, I don't think it was the goal of this article, but it gets touched on a little bit, is then a lot of families really remarkably delay food introductions. And then that has its own, I think, host of negative sequelae, like oral aversions and things that can happen in babies that don't get it introduced in an appropriate time.
Yeah. And some of the things that they noted, older maternal age was a slightly higher risk. But to your point, late introduction of complementary foods after 7 months was odds ratio of 3.5. That's pretty impressive to be more of a picky eater. And those that breastfed less than 6 months also had an odds ratio of 2, or double the incidence of picky eating. From a primary care standpoint, I think it just emphasizes that maybe if we haven't already over the past decade or so changed the way we counsel about feeding, it's time to rethink what we're doing.
Sure.
And, allow babies that time, because I've always believed that we should emphasize that mealtime is about feeding and nutrition, but it's also about socialization.
Yeah.
And I think, if we make it social, make it fun, make it relaxed, I think everyone does better. And if the parents feel better, the baby, I think, to this study does better. And it'll be interesting to see if this replicates itself, because it gives us just something that we can counsel our patients about to give them confidence about moving forward. And really, that's a big part of primary care, is helping families have that confidence forward. So did you see anything else of interest in that?
Well, I looked up they mentioned in the discussion this prior, I think it was Bliss trial, which was, because this is, like you mentioned, a cross-sectional study where they kind of are interviewing these moms on what they did. But this was actually a randomized clinical trial that they did in 200 infants in New Zealand. And their primary outcome they were looking at was to see if babies that did baby-led weaning versus traditional methods of kind of spoon feeding, if those babies had a lower BMI. So somehow they're less likely to overeat than babies that are spoon-fed. And they did not find anything in terms of BMI, but their secondary outcome was looking at other things like picky eating.
Right.
And they, I think, only followed them for like a year. So they didn't have as long, but they found no signal in BMI, but they did find, again, a signal in picky eating 1 year out. Which then this study takes that, again, cross-sectional, different cohort, but they take it a little bit further in this like 2 to 5 age group of looking at picky eating. And I guess it was in this study too, they said it was the babies that did strict baby-led weaning that had the most pronounced improvement in their picky eating. But even the ones that had some baby-led weaning had some improvement. They did a bunch of different, they cut the pie they sliced it a couple different ways, which I think is okay. They did these sensitivity analyses to do that. But I think one of the things with parenting and with our families too is that sometimes you can do baby-led weaning and that's great. And sometimes maybe your family situation doesn't allow that at that time, And so I think parents, especially around this time, is like a high stress time and wanting to do everything right and everything perfect. And so that, maybe you can do some baby-led weaning, but don't panic if grandma spoon-fed, baby food either, so that it's all, okay. I remember with my first, I was like, we're going to home make all of our baby food, and we did squash, and I spent forever chopping up squash. And then I tried to give it to my oldest son, and he turned it down immediately. I spent hours as a fellow on a Sunday making squash, and he immediately was like, I'm not eating that. So and then I immediately was like, well, we're not going to home make food,
Right.
So I think I think when family look at this stuff, they're like, oh, now I need to 90% exclusively baby-led, feeding. And I think that's too much pressure.
Right.
And I
Well,
think
it's
parents put
the
pressure.
same with breastfeeding, right? We talk
Yeah.
about all the great benefits of breastfeeding, exclusively breastfeeding. Maybe to a fault sometimes that we make those where it's not feasible all the time, maybe to introduce guilt and things like that. So we always have to be, I think, measured and balanced in how we counsel it and be supported.
I agree. And, we also don't know, this was looking at 2 to 5 years of age. These children were more picky, and by, a significant margin. But I think we all know those picky 3-year-olds that now have these robust palates as teenagers and beyond. And so, so I think again, tempering the recommendations with trying not to panic induce that maybe this isn't how I fed my child, and that's okay. And maybe it doesn't work for your family all the time, and that's okay.
Just goes to show you, I think there's so much nuance in how we communicate with patients that it's really, we've got to get away from being so black and white sometimes and understand each situation. But no, I found that interesting. That was a great article. Thanks for helping break that out. So I think they probably want us to wrap up, but we're not going to stop because we got more to talk about. Okay, so we're gonna
What more? We can do this one quick.
We can do this one, and we talked about this a little earlier. This one is right up your wheelhouse. I think you just presented it last week. So I'll introduce the article, but I'm going to throw it to you to take this one. So this is acute gastroenteritis as a risk factor for development of disorders in gut-brain interaction in children. And this is from the American Journal of Gastroenterology. This is from January of 2026. And before we start, let's just define disorders of gut-brain interaction. This is sort of what we used to call functional abdominal pain and what fell into that criteria.
Yeah, and I think it's a part of that nomenclature, right? People that are in pain all the time, is that functional, right? So, but we called it functional because it didn't have necessarily an organic cause, like inflammatory bowel disease or celiac or an ulcer. So we would call it functional, but that felt like not a great term. Irritable bowel syndrome is a type of disorder of gut-brain interaction, but it's basically the umbrella term that includes these kids that have chronic nausea or have irritable bowel syndrome, constipation, diarrhea predominant, et cetera. So it's kind of an umbrella term that captures all of those children.
They looked at 50 children, I believe, and they matched them with sibling controls. And these are children, I think, that were prospectively enrolled and identified that when they had an acute gastroenteritis, they looked at the severity and everything else. And then they looked at follow-up at 3 months and 6 months. And they did find that there was a large, or an increase, I should say, in these symptoms at 3 months and 6 months. You want to comment on that? Or?
Yeah, I think that's one of the things that we see commonly that gets referred to our clinic is these kids that clearly had what was a gastroenteritis and then had some persistent pain, diarrhea symptoms to follow. And I think this article kind of highlighted just how common that is because people haven't really looked that much in kids in prospective cohorts. And I think ultimately it needs to be looked at even further longitudinally, but most of the adult data suggests that these kids ultimately will get better. And so these are things that we need to maybe treat in the short term, but also some reassurance to these families that this isn't necessarily unexpected. I think is a really important point as well. We're learning more about the these gut-brain interactions, which I think is really fascinating. So the vagus nerve, as you know, connects the brain with the gut. And the classic thinking is that most of the signaling pathways would go brain to gut. So if you're feeling anxious, that's telling your brain, your gut to spasm or become hyperactive and have pain and diarrhea. But now they're looking at that the gut actually, a lot of the signals go from gut to brain as well. And so what does that mean for our patients that have chronic GI distress? And so we know that there's microbial metabolites that are serotonin metabolites and dopamine metabolites that can get absorbed in it. So I think there's a lot more to look at the role of our microbiome in kind of chronic pain conditions as well as mental health conditions that we still don't fully understand. And I think it's going to get unraveled more in the next decade, I hope.
And I think they looked at a little bit of the prevalence of anxiety and things like the population, which there wasn't a large number this year, but again, just for numbers' sake, by 6 months, there was, I think, 10% of the patients enrolled had significant continued kind of chronic symptoms. And I think this, and I've seen this, and most of my clinical work now is in the urgent care field, but I've had a couple of patients recently, very similar, where they come back because they're concerned of persistent pain or persistent symptoms.
Yeah.
And it reminds me of back in the day, we used to talk about infants who would have a GI illness, and we talked about slick gut or those sorts of things where they seem to have digestive problems that linger for a long time. I think the strength of this is it gives us something to hang our hat on to tell these families, again, for counseling and reassurance, this is something that, the words we use so often, we see this. We see this all the time. We know that this can happen, but in the long term,
they're going
to do very, very well.
The other thing I always try to remind families, and it's really easy for me to say as somebody that doesn't have a child that's hurting, but what we know about these disorders of gut-brain interaction is that I think a lot of times we think, well, we just have to improve the pain and then they'll get back to school and then they'll get back to basketball and gymnastics and all the things. But what actually we know and has been shown is that if you can restore the function first, then the pain will get better second. So instead of just focusing on, we need to get you pain relief as our first step, if you can actually get them back to school, the pain will fix itself in a lot of these kids. So that's, again, it's hard, and that requires partnership with the schools and with the families and a lot of buy-in. And we have a psychologist in our clinic. We're very fortunate to have an amazing psychologist that helps with a lot of that. But I think sometimes how we have to think about returning these children to their day-to-day activities looks a little bit different than we would think about with some other.
You're sort of retraining how they're interpreting the pain.
Correct.
And that helps the family, I'm sure, because so many, I think, are worried about, is there some tumor or some cancer?
Yeah, the big scary thing.
Yeah, so we've got to reassure them as far as that goes. Going off script here a little bit because it's what in the study, but since we talk about it, do you use a lot of probiotics or things like that in this field? Pros, cons to that?
So I don't use a lot of probiotics. And the reason for that is so probiotics are technically regulated more in the food category. So as opposed to like a medication category. So they don't have to go the same type of kind of drug study. And so because of that, most of them haven't been shown to have benefit in reliable ways. And the only benefit of probiotics has been shown to decrease slightly the degree of the duration of antibiotic-associated diarrhea by 1 or 2 days. There was and again, I study C. diff, and so there was a lot of interest in probiotics for C. diff early on because this is such a clear antibiotic-associated infection. And at first I was like, well, there's a little bit of evidence they may be helpful. And then they had bigger studies that showed it really probably wasn't making a difference. But I was like, well, it's probably also not hurting, right? But they are expensive for these families to stay on. And then a more recent study came out in a mouse model of C. diff. So it's not for all conditions, but of C. diff. And it demonstrated that you actually delayed microbial recovery by giving probiotics to the mice.
Interesting.
So now I kind of let their bodies do it themselves. I recommend anybody who studies the microbiome recommends these things. So this is not novel to me in any way, shape, or form. But it's fiber. I think protein is having a moment right now, but anybody that likes the microbiome feels like fiber could be protein any day of the week. And it's fiber from fruits and vegetables. It's natural fibers. The synthetic fibers don't do it. And then fermented foods are the second, if you can get fermented foods in the diet for microbiome recovery. That's harder because kids.
Just to be clear, what
Yeah.
define fermenting?
Yeah. So, and that's, it's generally things that are allowed kind of this period of time with yeast and bacteria to kind of replicate. So, kimchi, sauerkraut are kind of the biggest ones, kombucha. And those are not in most 4-year-olds' palates, right?
Maybe out of mine either, but
I met a 4-year-old that said that sauerkraut was their favorite food. I'm still looking. But I think sometimes the fiber, the fruits and vegetables are the easier, but that's not an easy sell for all kids either. So smoothies are a great way to get in a lot of really healthy fiber, natural fibers. But I prefer diet over probiotics in kids that maybe have some microbiome disturbance.
Well, I think that's a learning curve for me because I think I've used probiotics a lot in the past, and maybe for lack of other good things. But
Yeah,
this will kind
that's
of refocus me feel
Yeah.
good sometimes.
Sure.
This is great. And this paper obviously didn't get into the mechanisms of this, but is the thinking sort of that there's just some I don't know if it's particularly viral specific or other things, but there's some persistent inflammation and injury to the gut.
Probably there's some injury, including to the nervous system of the gut, probably some even to the vagus nerve that we don't fully understand and is really hard to study. And then probably some persistent microbial disturbances that kind of ruin that mucus barrier and persist with some degree of inflammation.
But we haven't defined a particular series like norovirus versus rotavirus or anything
No,
like that.
not in good ways. I will say that I think they looked at in that study, this more severe symptoms were more likely to result in, which kind of tracks with what I think we see. And they did notice too that the group that ended up having post-infectious IBS of a more severity, or DGBIs, also had IBS pre-infection. So again, I do think kids that are prone to kind of GI pain may get worse gastro as well, and then have worse pain afterwards. Sometimes you get in this cycle that can be challenging.
Well, that's a good reminder to take that history, right?
Yeah.
Is it in the family? And then you can kind of put the pieces together and explain to the family why this may be going on.
Yeah, totally agree.
Good. Well, great. Well, those were 3 great articles, and I appreciate you breaking them down for us. And so, again, thanks for your time, and thanks for everyone who was on today listening. I hope you got something out of this. And again, we want to make this something productive for you. So if you've got questions about any of the articles we reviewed today, or if you've got ideas for topics you want to cover in the future, email us, please, cpfnashville@gmail.com. And for questions related to this, I can hunt Dr. Nicholson down. We can get back with you, and we look forward to seeing you in future episodes. Thanks for joining us.
Thank you for joining Cumberland Conversations. We're proud to support the people who care for Tennessee's children. Don't forget to subscribe so you never miss an episode, and stay connected with CPF for more tools, trainings, and community updates. Until next time, take care.